Hello friends, today I am going to show you few cases where I have difficulty with IOL implantation. These 4 cases I have collected over a period of 7 to 8 months. The type of IOL used for this surgery is also mentioned in the respective case. You can see these videos and consider it as a surgical audit to correct my own mistakes. This first case is where I was supposed to implant Acrylic multifocal IOL and two haptics got stuck to each other at the tip. Definitely I could release these haptics without an issue, but having a multifocal patient and simultaneously having these type of difficulties with IOL implantation is worrisome. Probably using a drop of visco and folding the IOL haptics a bit less prevent overcrowding might have been the solution to this case. I could finish the case without an issue. I used my left hand instrument wisely and my coaxial IA probe to release these two haptics from each other. Going towards the second case where phaco and IA part is finished in a smooth way. In all these cases I have used 2.6 keratome as a main port incision. This case was also a multifocal hydrophobic IOL. And both the haptics were stuck to the optic. I started manipulating with my IA probe and left hand dialer, but I could not release. Now going for attempt 2 to release these haptics from optic. Hope the things will work good this time. The mistake which I was doing here is I was not using a micro forceps, which I should have used in a first attempt. If you have similar situation, it is good thing that you use the micro forceps. Hold your optic with this, and with the second micro forceps release the IOL haptics. This will be the effective and the best way which I realized I should have done in first attempt itself. Thankfully, without PCR, I could place a multifocal IOL in the bag without an issue. Going towards the third case. In this case, I had an issue with a plunger which could not push the IOL forward, and IOL got stuck halfway in the corneal wound. I finished my phaco part normally without an issue. In this video, few of the steps of some surgeries are fast forwarded just to save the time. But as I proceed with my implantation part, I could not push the IOL forward and realize that even on pushing plunger to the full extent, IOL is not going forward and it was stuck in a corneal wound. I'm pushing this IOL, but it is not going forward. So what is an issue? Why this IOL is not going forward? Why my plunger is stuck? It is the rubber pellet of a plunger which was at fault in this case. This IOL was stuck in cartridge, so I had to cut it open and remove the IOL. Reloading the IOL in another cartridge and implanting IOL without an issue second time. Here, on simultaneously seeing both these images, you will realize the plunger rubber tip was at fault on first attempt. Thankfully, I could finish up this case without an issue. Going towards the fourth case, which was the most dangerous and most horrifying to my experience till now, is the toric IOL implantation, which has multiple issues. The surgical part itself was difficult as I noticed a lens is having a coloboma exactly sub-incisional. It was a small coloboma, but had extended rexis at the same location, which I had to cut open, and still having some extended part of rexis in the same region. So I was worried for extension of this rexis part posteriorly and causing PCR in a topical case of toric IOL implantation. I had to use micro scissors forceps to finish up this rexis, a high density visco materials for manipulation. Could finish phaco part without an issue. Was happy. Surgeon, I was a bit worried about implantation of this IOL as coloboma was located exactly below incision, and I do not wanted to create undue pressure over this colobomatous area, which has extended rexis additionally in the same location. My mind was preoccupied with this defect and was worried for IOL implantation too. Probably this could have led to sequential events of mistakes and which has led to a disaster. My IOL got stuck in a cartridge which I could not push forward with my plunger. Again, I have to intervene to remove this IOL out of cartridge. So I decided to cut the cartridge into two. As soon as I take the decision to cut it and I went to cut the cartridge, I see the two sides of an optic are coming out of a cartridge outside the wound with cut on each side on a optic. Haptic was still in a section and the I have my optic half in the anterior chamber, half out of the section and cut open over there. I tried to fold it up and pushed the IOL inside, but I couldn't. I tried to extend the corneal wound so that I can push the IOL in, but could not do it successfully as the wound was overcrowded. Patient was under topical anesthesia and started to make complaint about the pain he is getting. I just took a break for 30 seconds and thought what I should do. I went in and cut the IOL outer side and removed the rest of the IOL out of the bag and did a simple hydrophobic IOL implantation which was not toric, as the same IOL toric power was not available with me. People may have different opinions regarding the management of such scenario. It can be 100% correct or wrong. I had to apply 2 sutures to close this wound as I had extended this and finished the case. Patient did well in a post-op period, though he was having some cylindrical power residual. I have collected and presented these cases just to show the mistakes which can happen during IOL implantation. Similar situation can happen to anyone. This video demonstration targets to look at these mistakes and not to repeat the similar mistakes for ourselves. And these scenarios may help someone to take a wise decision and a timely intervention to prevent further complications in such cases. Thank you for your patience. Do subscribe to YouTube channel Dr. Pankaj Lande.